On the Scene video coverage of AHA 2012 is supported by Pradaxa.
Welcome to On the Scene at AHA 2012. I'm here with editors of JACC and Axel, Dr. Tony DeMaria and Dr. Fred Bove, and we'll be talking about the late-breaking clinical trials that are headlined today by the Freedom Trial. Now, this is a long-awaited study that looked at the ever-present issue of how to best revascularize patients with diabetes and preserved LV function, whether one could go to PCI or CABG. I think we saw a pretty clear result with favoring CABG. Tony, what was your thought about this?
Well, it was an extremely well-designed trial, just under 2,000 patients, well randomized, as you say, multi-vessel coronary disease, diabetic patients, and in fact, clearly CABG was superior. What impressed me was that it was superior not only for revascularization, which has kind of been a recurrent theme comparing PCI and CABG, but also for mortality. Stroke was a bit higher in the CABG group, and that was the only negative in terms of CABG versus PCI.
Yeah. Fred, what was your take on?
Well, you know, we've seen some signals in prior trials, all the way back to Barry, that suggested that surgery might be a better choice in diabetics, and this is another well-designed trial that more or less supports that perception that somehow the diabetic population does better when they have bypass surgery in PCI.
Yeah. Certainly suggestive of the diffuseness of disease. Interestingly, the curves really looked a little worse for CABG, probably the early perioperative stroke driving that. But then at 1 year identical, 2 year not much difference, and really between years 2 and 5 is where this advantage emerged, with an 8% absolute mortality benefit, which I think is sort of, okay, this is something we really need to pay attention to.
Yeah, I think that if you look at this study, they really insisted that the interventionalists be at the higher caliber, lots of experience. They insisted on drug-eluting stents. By and large, they had optimal antithrombotic therapy. It was well designed in that regard. So that, of course, one of the issues always is, has PCI advanced now, and if we did the latest PCI, would they do better? And that will always be a question, of course, but this was pretty darn good PCI.
Yeah. I have to say, you know, clinically, we've often sent, LV dysfunction was not studied here. This was preserved LV function. And, judging by the diffuseness of the disease and the syntax score would drive some people, if it weren't too bad, to PCI. I think now we have to kind of think twice about whether it should be a more routine referral for CABG.
Right, and they did look at subsets with different syntax scores, and across the different scores, the outcomes were about the same as the major outcomes. So the syntax score seems to be less critical in this population.
Yeah, this may reinvigorate cardiac surgical training programs, which have withered a bit as PCI came along.
Yeah, well, it's a terrific result. I'm sure we'll all be poring over the details, and then we face this on an almost daily basis, with the rising tide of diabetes and coronary disease, that this will be probably an almost daily discussion on rounds to see how do we optimally manage these patients. Well, next up, we had an interesting look at long-term antithrombotic therapy for pulmonary embolism and DVT, a study looking at whether antiplatelet therapy with aspirin could provide some benefit. And this, as a trialist, was one of those really tough ones that you have a p-value of 0.09 for the primary endpoint. But I think some intriguing data on the benefits of antiplatelet therapy. Fred, what was your sense about this study?
Well, there's two things to think about. Number one, as cardiologists, we don't always get involved in treatment of DVT. It's more on the internal medicine group. But the question that comes up all the time is, how long do you go with warfarin anticoagulation, and then what do you do after that? And I think this is one of the studies that gives you some insight into how to deal with that. The The warfarin was ended at a reasonable period of time, 3 or 4 months after initial symptoms, and then the question was, should you continue with antiplatelet therapy? And it looks to me like continuing aspirin over the next couple of years does in fact reduce the incidence of DVTs. It was just barely significant, or maybe slightly not significant, but pretty compelling data actually.
Yeah. I think they also pointed out that there were reductions in arterial events, so cardiovascular death, MI, also reduced as you'd expect. Almost a reminder that if you come in with one thing, often you'll have other risk factors or arterial disease.
Yeah, we haven't often thought of venous thromboembolism as a risk factor for atherosclerosis, but you have to wonder because there was a significant benefit in these patients. Wasn't clear what their coronary profile was, and they might have oversold it just a bit when they said compelling evidence for aspirin based on recurrent VTE and vascular events, but for VTE, as Fred said, it was close, but not quite statistically significant.
Right. And I think there have been 1 or 2 other studies, so hopefully someone will put those together and get a broader look. The final.
Interestingly, less interestingly, no greater bleeding with aspirin. So you might have thought, well, I'm trading less VTE for more bleeding, but it wasn't statistically significant.
I think that's a very good point, because that's often what holds people back from treating, and with a reasonable size, about an 800 patient trial, so not huge, but a reasonable size. Well, the last one was an area that you've both worked in, looking at myocardial contrast to support stress echo and whether that could help, as you'd imagine. The POISE trial. Fred, you want to describe that one a little bit?
This raises an interesting question. I mean, you have echo contrast, and people use it when they're doing wall motion abnormalities to get better definition of endocardial surfaces, and that's been approved by the FDA. So people use it frequently, and at the same time that contrast is going into the myocardium and producing a flow pattern or a wash-in, wash-out pattern. And there's been a history, probably for more than 50 years, of how to use that kind of kinetic change in density of contrast material, or in this case the density of contrast microbubbles, to deduce something about myocardial blood flow. The group here, single center study, looking at intermediate risk patients referred to the stress lab, randomized to a stress echo or a stress dobutamine versus a stress echo, stress dobutamine with contrast and densitometric measures in the myocardium. The finding was marginal, but I think they were able to show that if you interpreted the densitometric changes in the myocardium in addition to the wall motion, you got a little more discrimination in finding the high-risk patient. So, and it was not mathematical. I mean, you can do these mathematical analyses. It was trained observers knowing how to see the changes in myocardial density that was able to pick out with the wall motion abnormalities the higher-risk patients.
Yeah, I thought the impressive thing, the myocardial contrast echo has been around for a while, and it's really been tough to show its value. I thought the impressive thing was that adding the contrast perfusion to wall motion had a beneficial effect in predicting events, not just positive, negative, but events, and that was the high point. But it was single center and done by one of the 2 or 3 individuals in the world who's had the most experience, and even their study showed that this is not an easy technique, and to make it accurate, you need to have lots and lots of experience.
Yeah. Okay, well, so maybe if you get into that area, this could be a way to enhance things. Well, stay tuned with us as we cover more of the late-breaking trials here from AHA 2012.